Going to see how to perform the neurological examination of the cranial nerves. Not all the tests of the examination for the cranial nerves, but the most important to do, and the emphasis on how and when are we going to do it. So it is better to learn the cranial nerve exploration in clusters more than to know I will test the 1, 2, 3, 4, etc. So let's do it in clusters. We have the first cluster would be the cluster of just one cranial nerve, that would be the olfactory. Then we would move to the second cluster that includes the eyes. So these are the eyes, and we are testing the second, third, 4, 6, and in the vestibular part of the vestibulocochlear nerve, so 8. Then we move to the trigeminous nerve, so the facial, the trigeminous nerve, trigeminal nerve. So this would be like the sensation. So let me put sensation, sensation. All right, trigeminal nerve. Then the facial nerve, then we will go back to the 8. Now just the auditive part, 8. Then those of the speak and swallowing, this will include the 9, 10, and 12, and then the 11th. Alright, so in the olfactory nerve, well, this is just we will give the patient like 3 kind of different things, and we will ask the patient to smell it. We always want to carry things on the pocket of the black coat in order to every patient that we want to do the neurological examination. We just put it. This could be coffee. We can carry a small container with coffee. So could be coffee, and could be, if we are on the patient's room, we can get close to the soup, or maybe money or something like that. So it's just the smell, because a lot of diseases can present with smell troubles, like if the patient has a trauma to the back of the head, that can damage the claviform plate, or if the patient has, for example, Parkinson's disease that affects the cranial nerves, and one very common affected would be the olfactory nerve. Many physicians just test from 2 to 12, and why we will not include the 1, and also it's very simple to do it. Alright, let's continue. For the eyes, we will do the fundus examination. We want to see the pulsation of the retinal veins, and we will see that everything is okay. We are not doing a detailed examination of the fundus because we are not ophthalmologists. This is just a neurological exam, and we are not going to dilate the pupil because we will also need to see the reflex of the pupil. So we will do the fundus. Then we are going to test the visual fields. We could ask the patient to read a chart, first without correction, and then with correction we can give the glasses, that in order to see if it needs glasses, for example, or something like that. And then the visual field. So well, this was visual acuity, and then the visual field. The visual field is how large is the visual field of the patient. So that is, we will ask the patient to just look at us straight, and we will ask the patient to tell us when sees that the finger comes to the visual field. So here I don't see the finger, I don't see it, and now I begin to see it. So actually you can see that here then is my blind spot of this eye. Alright, but what if the patient is not very cooperative, and even though you are saying the patient, don't look at the finger, and the patient continue to see the finger, what would you do? You can surprise the patient with flashes, so you can just the patient is looking at you, but you know that when you put the finger to some place, the patient is going to see it. So you are just like this, and look, here is the patient, and you would do something that surprises the patient. For example, something like this or like this, and we will ask the patient that if the patient does that, or you could do it with the hand, something like that. So if I'm the patient, I would see that the doctor does something like this, and the doctor would say, do you see the hand, something like that. And yes, obviously the patient is going to turn something like that, but the doctor already moved the hand, so it was something like this. So there are like flashes like this, or with the finger. And to test it better, once you prepare the patient for that, you could not do it just with the hand. That is, you will show some number. Could be two, could be 5, or could be 1, but not 3 and 4, because 3 and 4 looks very similar. And also, what's 3, 4? So don't. We will do 2, 5, or 1. So you could do this, or this, 2, something like that. And you can do it in every quadrant. So you would test this quadrant, then for example this quadrant, or something like that, and the patient needs to see how many fingers were there. And after this, you could do it in both quadrants, like how many fingers did I put, something like this, and so the patient would have 5 and 2, something like that. And so even though the patient is non-cooperative, we could do this. Next point. Now we will go to the third cranial nerve. So in the third cranial nerve, we will test the pupils. We will see the meiosis. So we will do the direct. We will look for the direct reflex, the consensual reflex, and the near reflex. So we will just look at the pupil. We will put flash light on this eye, and we will see constriction of this pupil, direct reflex. Then see constriction of the contralateral pupil, consensual reflex. And then we will ask the patient to see a near object like this thumb, for example, and we need to see that the pupils constrict. Here we are not doing the convergence test, because in convergence test we will ask the patient to see, for example, the thumb, and we need to see the accommodation. Here we're not doing accommodation, in which case we need to see that the patient sees better the finger. So it's here and then this, but we are not testing how nice the patient is seeing this, how well the patient is seeing, how is the acuity on that part. Also, it could be different for the patient and for the doctor. So we're not testing that, we're using the response of the pupils. So direct, consensual, and near reflex. Next, the movement of the eyes. So first we will do saccades. Saccades is the rapid eye movement. So we will say, look to the right, look to the left, up, down, something like that. And these are just saccades. Quickly goes to one side or the other, and certainly also you could see if there is a third cranial nerve damage here, or if a sixth cranial nerve damage with inability to put one eye to the lateral side, or the medial, or the eye to the medial side, depending on which part the eye is looking. And also you can see the internuclear ophthalmoplegia. That is, if the patient, you ask the patient, let's say, turn to the right, and this eye looks to the right, this eye cannot look to the right, but if you do convergence, you will see that both eyes look to the nose, or to the object that is near. So we could see cranial nerve abnormalities there, and sometimes the internuclear ophthalmoplegia. So this was for the saccades. Now the slow movement of the eye. So we will ask the patient to follow the finger of the doctor. So we will ask something like this, without moving the head. So here, here, up, down, something like that. And you can see that if it is very slowly, we just look at here or here. Sorry, I moved the head. We just move the eyes slowly because the doctor is moving the finger slowly. But we can see that there is correction. If we don't do it very slowly, the movement of the finger, and we just do it, for example, like this, we will see that the movement of the eyes goes like not straight like this when we were moving the finger. It would be like in steps. So something like that. I cannot do it. Something like that. So it is on steps. Here, steps. Anyway, the other one, at this point we have tested the 2, 3, 4, and 6 cranial nerves. Now let's go to the vestibular part. So on the vestibular part, when we are for example, turning the head of the patient toward one side, the eyes look towards the side of which the head is looking. Now let's put the eyes fixed at one point. So we will ask the patient to just see an object, and we will turn the head, but the eyes look towards that object. So the head is turning, for example, to the right, but the eyes are going to the left because we are fixing the vision. So now, if there is damage to the vestibulocular reflex, the patient can have a damage to the 8th cranial nerve in this case. So when there is damage, or let's first do the physiology. In the physiology is, look, when I'm turning to the right, the eyes look to the left. So go to the contralateral side. Now, if there is damage to the vestibular part, let's say of the right side, then the left side is going to win. And so it is like if we were moving the head towards the left, that this implies that the eyes look to the side of the lesion, to the right. So I'm turning the head to the left, to the left, and the eyes look to the right. So if there is damage to the vestibular nerve, we will see that the eyes on this test would look to the side of the lesion. So here we are just testing it, and we see that it is normal because when we move the head, the eyes look to the contralateral side. But let's say the patient has damage to this right side, so the patient is not going to be able to, when we turn the head to the right, the eyes will not be able to look to the left, so the eyes will look to the right. So we look to the ipsilateral side of the lesion. We could test this if the patient is on the bed. We can put warm water. If we put warm water where it is like stimulating the vestibular nerve. So it is like if we were moving the head towards the right. So we will see that if we think that the eyes go to the left, then that is the vestibulocular reflex is intact. Other way to do it is with cold water. Now with cold water we're stimulating a lesion. So if we put cold water on this right side, we're expecting the normal response is that the eyes look towards the side of the stimulated lesion of the right. But if we see that the eyes look to the other side, that's normal. Or other test is, this with the vestibulocular reflex, the mnemonic is Cada. And because when we're putting either cold water or warm water, look, if we put warm water first, the eyes would look, I put warm water here. So it is like if the head were moving towards the right. So the the um, the eyes would look to the left. But because there were no movement of the head, then the eyes would compensate, going against to the right side. So the eyes are looking to the contralateral side, but then they rapidly correct, and so we call this a nystagmus. And the nystagmus has this slow phase and the rapid phase. The rapid phase is the name of the nystagmus, so this would be a nystagmus to the ipsilateral side at which we put the warm water, so the ipsilateral side that is simulating being stimulated. Now, when we put cold water, we are simulating a damage. So the eyes would look, I said, to the side of the lesion, but because there were no movement of the head, the eyes would correct and would look contralateral of the side of the lesion. So here the nystagmus is to the contralateral side of the simulated lesion. So the mnemonic is cow, 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 cow. So contralateral, cold water goes to the opposite side, and warm water will go to the ipsilateral side, the nystagmus. Alright, so ka, 1, 2. Anyway, forget that if that confuses you, the mnemonic. Anyway, now, so at this moment we have tested the eye cluster, and the eye cluster includes the second, third, fourth, sixth, and eighth cranial nerve. Well, just a part of the eighth cranial nerve. Now let's go to the trigeminal nerve. So here we are just going to test like the 5 branches of the trigeminus with sensation and temperature. So the sensation, the only thing that we would say the patient is, does this feel the same thing on both sides? Here, on the mandibular branch, yes. And the maxillar branch now, here, yes. And the ophthalmic branch, here and here, yes. We would not do suggestive questions like, here, did you feel here more whatever, more cold, more warm than here? And we will not give this suggestive. And we will also don't say something like, if this is 1 cent, how much is this? Because we can skew the patient and say, oh, I don't know, I cannot say the same thing, it's 75 cents or whatever. Not because the patient is inventing it, but we are doing a suggestive, we are giving a question that is suggesting the response. So we will just say, does this feel the same? Yes. Here, yes. Here and here, yes. That's all. For sensation, whatever, and cold, we can usually with the diapason. The diapason is cold, so we will put the diapason and we will see that the temperature is kind of the same. Unless the patient specifies something like there is numbness of the face or something like that, we will just do that, like that of quickly. For the muscles of the mastication would be a little difficult to test. We will ask the patient to close the teeth like this. We will see that we are just seeing the force of the muscles here. We're not seeing the skills, no. We're just seeing the force of the muscles. We could ask the patient to move the mandible around like this. We could ask the patient to open the jaw, and we will try to close it. So we will ask the patient, don't let me close the jaw. So the patient does this and cannot close it. Alright, now the facial nerve. Alright, in the neurological examination, we don't need to follow the let's say the list of, or the order of mental status examination, cranial nerve, motor, sensitive, gait and coordination and reflexes, or reflexes and gaits. This is variable. There is, in any one of these 7 that I said, there is no need to do it at this order. We encourage that doctors do it at the same order all the time, because we don't want to lose any examination. But there is no need to do it in this order, like mental status examination, then cranial nerves, etc. But we usually do it in that manner. So, if we already have done the mental status examination, we already have seen the patient to talk, speak, etc. So, at this moment, we will see, for example, if the patient is talking, and we are seeing that both corners are moving normally, both eyes are blinking, both eyes are doing, both muscles of the face are doing everything. There is no need to think that there is a damage to the facial nerve, to the seventh cranial nerve. But if you want to test it, you can see, for example, you could ask the patient to smile, and if there is the smile is going towards just one side, that is because this side cannot be contracted. These muscles of the face have not been contracted, and so the damage is of this side that is not. The smile is not going to touch. So this smile could be, I cannot do it, but if you see just this on just this side, like this, then this would be the damage nerve. Alright. And you need to see if it is supranuclear or nuclear. Nuclear would be damage to the body of the nerve at the motor nucleus of the seventh, or at the peripheral nerve. So this would be a Bell's palsy or a peripheral nerve palsy, in which the front, the head and the lip would be unable to contract, nor for smile, nor to do the face of angry, for example. This, the patient would not be able to do it on this side. If the patient has Bell's palsy, if the patient has damage to the ipsilateral, and if has damage to the peripheral nerve. Additionally, these patients would have a metallic taste, and the metallic taste and hyperacusia. Hyperacusia is, remember that the seventh cranial nerve has the chorda tympani that innervates the stapedius muscle that helps to damp the sound. So if there is damage to the seventh cranial nerve, the patient will not damp the sound, and so is very uncomfortable. So a small or a sound would be perceived as a high sound or very strong sound. So the patient would be something like putting the hand in because it's hurting the patient. So the patient would present with these three things: the peripheral nerve palsy, inability to smile and contract this side of the head, metallic taste, and hyperacusia. This if it is a infra or nuclear or peripheral nerve palsy. Now, if there is damage to the seventh cranial nerve, pathway, because we have the cortex. This is the upper motor neuron. This is the lower motor neuron, and here we are not talking about the anterior horns of the spinal cord. We are talking about the motor nucleus of the seventh cranial nerve, and we are doing the corticobulbar pathway. So this is called the cranial nerve because remember that the peripheral nerve is just the motor axon, the motor alpha motor neuron, and the dendrites of the nerves that are on the dorsal root ganglion. Anyway, so this is the peripheral nerve. So in this case, this would be the nerve, the seventh cranial nerve. This is not part of the seventh cranial nerve, but if there is damage to this upper motor neuron, this manifests as a damage to the, I would not say seventh cranial nerve because this is not being damaged, but is damage to the seventh cranial nerve response, for example, or efferent. So the patient would present the same with inability to smile from this side. If it damaged the contralateral side, would not be able to smile of this side, but this part of the head can be, we don't do this because there is innervation of the contralateral side also to that part of the head, to the motor, the these motor neurons, inferior motor neurons that go to the head. Alright, so and this is just to distinguish between a central or peripheral nerve palsy. There are other ways to test, other functions to test of the seventh cranial nerve that include the anterior two-thirds of the tongue, the flavor. But for this, we will to test with different solutions, etc. And we will not do this on the neurological examination quickly as this. Alright, so we will continue now with the eighth cranial nerve. And for the eighth cranial nerve, we would ask first the patient would tell us if it is a hearing loss. I don't hear this side, etc. Or we could notice it as we talk or something like that. So the first step is there a hearing loss? Hearing loss. Then we will see if it is a conductive hearing loss or a sensory neural hearing loss. We could do the René and Weber test. Weber test is, you put the tuning fork here in front of the head, but we will not do this because if we do this in a quiet room, it would be okay. But we are not doing it in a quiet room, and so the patient would say, I don't know, it's going to the right, it's going behind me, I don't know, so it's not going to be very precise. So we will not do Weber. We have then other things to do. And so we will do René test. René test, remember that the air conduction is better, here is better than the ear conduction or than the bone conduction. So here and here. And look, we will not ask the patient the classic test as here we put, for example, here I will put it here. I will say, tell me when it stops here, and because the air conduction is greater than the bone conduction, the patient should continue to listen a little bit, but it would be not precise. There could be a lot of noise, and the patient could have how do you say, that is because the tuning fork, sometimes you don't put a lot of pressure or something, so between the interval where you move it from here to here, maybe that stops, and so the patient will report, I don't hear it. So I don't hear it. No, I still don't hear it. So that would be a positive René test, but it's a false positive because that's not that the patient is not hearing it. So we will not do this classical test. We would do just this. Which is louder? You do this, and which is louder, here or here? Certainly the patient will say here. Okay, it's loud, and just like that. If the patient says here, so that it is a positive René test. So here the bone conduction is greater than the air conduction, and so there would be a conductive problem of the ipsilateral 8th cranial nerve. So if there is air conduction normal, so we already saw that there is, let's say the patient has hearing loss, and we saw that there is no conductive hearing loss because the René test was normal. The air conduction was greater than the bone conduction. Remember, I said if the bone conduction is greater than the air conduction, this is the conductive hearing loss of the ipsilateral side. So don't. Now, if we have air conduction, we will see, given that the patient has a hearing loss, we will see if it is, that is, we now know that this is a sensory neural hearing loss. The same way as if we would have done it with Weber and René, but we are not going to do Weber. So now the next step is to see if we have a retrocochlear or cochlear nerve damage. So the retrocochlear is, for example, a vestibular schwannoma or acoustic schwannoma, and for this test we will do the speak discrimination. So after we have decided or know that the patient has a neurosensory hearing loss that is not conductive, we will do a speak discrimination to see if it is a retrocochlear or cochlear. So to do this, we will put the finger of the doctor on the ear of the of the patient, and we will move this forward like this all the time, and the doctor is going to speak very quiet in this side. So let me put it like this. So this is the patient. I'm doing this like this, and I will here tell the patient some words, let's say 10 words, and the patient needs to repeat. So I said ice cream, okay, ice cream, then ice cream, and peanuts, peanuts, like that. We will do it. We will give 10 words on this side and 10 words doing this exactly same thing on this side. Let's say that the patient on this side said repeat 8 out of 10, and here 2 out of 10. Then this would be a sensory neural hearing loss of this side. Alright, so for hearing loss, you see we have a 3 process. First, it is the side we have a hearing loss. Then it is conductive or neurosensory hearing loss. If air conduction is greater than bone conduction, then it stays sensory neural hearing loss, and then we will see if it is retrocochlear or cochlear hearing loss. If the patient has on this test, 2 out of 10 and 8 out of 10, this is a yes, sensory neural hearing loss that we already saw, because conductive hearing loss was not the option, but this is meaning that the patient has a retrocochlear hearing loss. If we do this and this is abnormal, this test of the ear is abnormal, then it is a retrocochlear hearing loss. Alright, so we already saw the 8th cranial nerve. Now the cluster of the speak and swallow. Again, we have already done the mental status examination, so there is no need to test this, because we already saw how is the patient talking, if it has dysarthria or it is talking with a nasal speak, something like that. So there would be no need to do it, but if we want to do it, we could say the patient to repeat words like la. This would be to test the 12th, 10th cranial nerve, and sometimes also the 7th. Anyway, depending on which cranial nerve would be if we ask the patient to say me, because for this we need to join the lips. Alright, so we will ask the patient to say la, 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 like 5 times. Also ta, 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 pa, 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 and ga, 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 5 times. Like la, 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 ta, 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 pa, 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 ga, 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 like this. And usually the patient would be able to do it. Also, we would see if the patient has trouble with repeating, for example, words that have a lot of S, like the British Constitution. This is for cerebellar test. It has nothing to do with the cranial nerve. We can also test it here because we're testing the speaking and repetition, but this is part, for example, of the mental status examination that we saw. Also, you could ask the patient to say pockety, 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 and also in the cerebellar damage we will see damage to this, that the patient will not be able, maybe would be able to say the words many times, but not with the emphasis of pockety, 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 or la 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 la, would say la la la, no, I don't know, not putting the emphasis. So also you are seeing that the patient has trouble with speaking, dysarthria. If the patient has a 10th cranial nerve damage, that is the palate is falling, so the patient will have a nasal speak, and maybe the patient is all the time using a tissue because it's choking, so all the time needs to clear the throat, etc. And we will ask now to protrude this throat, to say, or well, to say and we want to see we will not see the uvula. We would look to the raphe, and this same way, if the raphe is deviated to the right, then there is damage to the 10th cranial nerve of the contralateral side. The same way as we learn it with the uvula, but we are not going to see the uvula, we are going to see the reflex. Alright, and lastly, we will ask the patient to do the movements of the tongue with the tongue, moving protrude the tongues. First, the protrusion of the tongue like this, and we will see if there is movement of the tongue or tongue. But don't think that any movement of the tongue is abnormal. Don't. This could be just normal fasciculations, but there will be no damage. If there is atrophy of the tongue, the patient would be completely on a dysarthria, and there would be no doubt that the patient has dysarthria. If you want to test the strength of the muscles, you could put the finger of the patient on the cheek, and you would say, push it with the tongue like this. Push it with the other, like this, and that's all. What else? So this is the cluster of the beak and swallows. And lastly, the 11th cranial nerve that we usually don't test it. Here this 11th cranial nerve innervates the deltoid muscle and the trapezius muscle and the sternocleidomastoid muscle. So the classic test is we will ask the patient to lift the shoulders, and we will say, don't let me bend them. So here the patient, and we will say, don't let me bend them or down them. But here the patient sometimes that is what's the priority that we can overcome this powerful muscles. So patients with very musculature patients without or let's say patients with a lot of strength, even though they have 50% of atrophy on one side, we would not be able to overcome that muscle. So we will not do that. And on the other way, a woman with osteoporosis, very thin, we will do this, and we will fracture the bone. So we are not going to do this, or just slightly, but not. We are just going to see. We are just going to ask the patient to elevate the shoulders. We will see how fast can they go, and the symmetry of the elevation of the shoulders. That don't be one. This. So just the symmetry. I think I'm going to do it asymmetrically. So anyway, that and now we will test the. So here, and you can also now say the patient look to the right, to the left, flex the head, extend the head, and that's all. And for the sternocleidomastoid muscle, usually you put the hand here and you say, don't let me turn the head. So here, and supposedly you will need to see here the sternocleidomastoid, that's it. And on the other side, here you see like this. Other way to do it is, if you want to do it more fine, you will put the fingers here on this part of the head of the patient. The patient is it, and you will say, don't let me like put you thrown on the bed. So the patient will be putting pressure like here, and you will see both sternocleidomastoid muscles. So that is, we have tested the from 1 to 12 of the cranial nerves, and this could be very rapid manner, but here is slowly because I'm explaining it, and we will do it in clusters. First the olfactory nerve, then 2, 2nd, 3rd, 4th, 6th, and the vestibular part of the 8th, trigeminal nerve, 7th nerve, trigeminal nerve, remember quickly and don't solicit questions, facial nerve, and the 9, 10, and 11, we will also be suggesting that from the beginning of the mental status examination, so sometimes there will be no need to test them. The 8th, you're going to do this. Remember the three-thought process. Determine if there is hearing loss. It is conductive or sensory hearing loss. If this is sensory nerve hearing loss, then we will do speech discrimination to test if it is a speech discrimination. If it is the cochlear or retrocochlear damage. This cluster and the 11th cluster that usually there would be no need to do it, but we will do it. So we have the clusters. The other thing I wanted to say, here between the 5 and the 7 we have the Cornell Reflex. So we will ask we will give the patient for example here. Also for the 5 cranial we can give a noxious stimulus. For example, put this on the nose, the patient will retract because it's a noxious stimulus. If the patient does not retract, then there is an abnormality with the sensation of the face. The other is we will do this on the do the corneal reflex and see the blinking of the eyes. And look, if we put the tissue here and we see that only this eye closes, then there is problem with the facial nerve because the afferent is coming because we saw a efferent response. So it is a problem with the contraction of the muscles of the eyelid. So there would be a facial problem. But if we put the tissue and there is no blink on either side, then there is a problem with the afferent, so of the 5 cranial nerve. And this was the only point, just to see the difference between the 5 and 7 cranial nerve damage. So these are the cranial nerve examination.